Dr. Anusha Handral. I am consultant endocrinologist, diabetologist and obesity expert working at Manipal Hospital Whitefield, Bangalore. We are delighted to have Dr. Moinoddin. He is a bariatric surgeon in our hospital at Manipal Hospital Whitefield. And today we'll be discussing about obesity and its treatment. Now we know that obesity is a pandemic. We're seeing a lot of patients walking into OPD asking doubts regarding obesity and its treatment. So I think this podcast is going to be useful. I welcome sir to the show. So first question to you, what is obesity and how do we assess weight in routine OPD practice? We do the BMI classification.
Yes,
so can you please throw insights on this?
So basically obesity is accumulation of extra fat in the body. Obesity is quantified in the form of a BMI, body mass analysis. So body mass index we say as. Body mass index is calculated in the way that is weight in kgs by height in meters square. For example, if I am 80 kgs, 80 by, if I am 172 centimeters, 1.72 into 1.72. One value you will get. That is called body mass index. Body mass index is a scale to measure obesity. So usually body mass index should be less than 25 according to the Western scale. 25 to 30 is overweight, 30 plus is obesity, and more than 40 is morbidly obesity, and 50 plus is super obesity. So, but what happens is, because we are Asian population, we have more of visceral fat. Our hands and legs are thin, we have more of tummy fat. Our BMI will be 2.5 BMI scale less than the Western. So what I feel is 22.5 plus is overweight.
For Asian population.
Asian population.
Okay. And about 25 is obesity.
Yes.
So there are other methods like sir said, BMI classification. This is simple. I mean, it can be done anywhere. In your house also you can do. But we have other methods of estimation. We can estimate the body composition through either body composition analyzer or DEXA scan. There are high level of CT and MRI machines, but BMI is something which we can do it in our office as well as at your house.
So apart from BMI, there is one more called body mass analysis. In the machine we do it. So relative calculations happens there. So what happens, how much percent of fat you have, how much minerals you have, how much water weight, extra body water. Many people don't know that they have edema. That edema also will result in excess weight. Once they lose some water fat, they feel like water weight, then they feel like they lost weight. Actually, it is not the fat weight. So if you should measure the BMI before going for any weight loss techniques, you should measure BMI, then you will know how much excess body water is there. That's always, I feel, that should be measured. So what happens is, many times they go outside and they see like, so we went to one treatment, we saw an ad, we went there, and within a week they may lose some 10 kgs. So it's a miracle. So it's not like that. It is the water weight. Water weight goes fast, comes back in the similar speed. So it is the fat weight which has to be measured. So don't get tricked with all the ads, fancy ads, because you should measure and you should visibly see the difference of fat percentage. If you are losing fat percentage, well and good. Follow the technique. Because being an endocrinologist, you see a lot of patients in this hospital. Why do you think there is a necessity to treat obesity?
Yeah. So that's a very good question because most of my patients ask, obesity is just the external fat. I'm not worried about external appearances. It's not the thing. Fat external also leads on to fat deposition in the internal organs, be it liver, intestines, and this is called visceral adipose tissue, which can lead on to insulin resistance, cardiovascular problems. So by far and large, we can classify obesity related complications into 3. So I always tell my patients 3 M's. What is the first M? It can lead on to metabolic problems like diabetes, hypertension, dyslipidemia, hyperuricemia, that is high uric acid, and women can have PCOS, polycystic ovarian syndrome, they can have infertility. The other aspect which is not really spoken is mental problems. They get into depression, they get into anxiety, body image disorders are there, sometimes suicidal tendencies. Problem with this, when they're depressed, they tend to eat more.
Correct.
And then again weight gain. So it kind of becomes a vicious cycle.
So basically, eating more gives them pleasure.
Pleasure. Other M, what I tell my patients is mechanical problems. A lot of overweight, obese patients, they're not able to walk. Their exercise capacity is reduced. They get breathless. And many of them have sleep apnea.
Yes.
Sleep apnea gets noticed. Whenever I ask the patients, do you snore? either husband or wife or children, they are amused by this question.
Correct.
So they don't know that snoring is also pathological.
Correct.
If not treated, it can lead to heart failure, lung related issues in long run. So snoring is important. That's why we ask all obese patients to get the sleep apnea study.
Correct.
And hence we should treat the obesity. Now another aspect is metabolic associated fatty liver disease. We see huge number of patients having fatty liver. They think it's just ultrasound, there is fatty liver, we'll do some diet and exercise. But if you don't have a significant weight loss, this metabolic associated fatty liver disease over a period of time leads to liver failure, like cirrhosis and liver failure. They may be requiring transplant at a later date. So it is very important we handle obesity for prevention of these 3 M's: metabolic, mechanical, as well as mental health issues.
Very nicely described, ma'am. Basically, anyone when you see from outside, you see obesity like mechanical mainly mostly. Because until unless you do test, you will not know you have diabetes, high cholesterol. Or externally, people will see you are struggling to walk, you're struggling to climb stairs, you're struggling to sit in a toilet seat. So that's what the visible. Mental also only the patient will know. Many young women, especially I see a lot of young women who are mentally depressed because of overweight. So they can't go out, the social stigma, they can't hang out, they can't wear the desired dresses. So this is a worry which I have. And definitely, as you said, PCOS and hypothyroid is a deadly combination which is gaining them weight. So, madam, you see a lot of patients. See, if you really see in obese patients, you see most common BMI is 25 to 30. This is a very grey area. How do you deal with this 25 to 30 BMI?
Yeah, that's a good question. So, obesity by far and large, I classify as 3 modes of treatment for obese individuals. Definitely investigating and ruling out other comorbidities which can be associated, be it diabetes, we'll check on their blood glucose levels, we'll check the blood pressure, we'll check on the lipid levels, we'll also check thyroid abnormalities. Some of them can have secondary causes of obesity apart from exogenous. Gets me to a question, by far and large, we have 2 types of obesity. First is essential, or what we call as exogenous obesity, largely because of genetic, diet and exercise. Second one is endocrine causes, be it sometimes cortisol excess, thyroid abnormalities, all of these can lead to obesity. So we definitely rule out the secondary causes of obesity. Now, for somebody who is having fatty liver, we definitely do a ultrasound fibroscan that will tell us what is happening with the liver fat. We do a sleep study to assess whether the snoring is really causing desaturation or oxygen levels getting down at night. We check on that. How do we treat obesity? It's a triangle: diet, exercise. And nowadays we see that a lot of patients reach out to us after doing diet and exercise. So the third component, which is very important, is medical management. Now, if somebody does not respond to all 3, then we have bariatric surgery or metabolic surgery, what we call. Patients have to eat. They keep asking me what they have to eat. Completely going on to any particular diet, be it keto diet or intermittent fasting, may be difficult for some patients. So I tell them, reduce the calorie, reduce the carbohydrates like simple carbs, be it rice, wheat or maida. They can go on to something like millets, which have huge fiber. They give satiety feeling. The quantity of carbohydrates comes down, and they can increase the proteins and fibers. Proteins will help in muscle building. Right, and fibers, they will not give you much calories, so let them increase the fibers in diet and reduce the portions of meal. This is with the diet. And coming on to exercise, what exercise they have to do? Anything whichever is feasible or they can do it. We generally recommend patients to do 30 minutes per day, minimum 5 days per week. If they're able to do more, better. Zumba, yoga, meditation, they can do some strength training at the gym. That is important. Cardio is also equally important. So based on whatever is feasible, they can do the exercise. Coming on to medicine. Now, we need to know that the obesity management has been revolutionized in the last few years because we have newer anti-obesity medications for treatment. So 25 to 30, if they fail diet and exercise for 6 months, then we can offer them anti-obesity medications. By far and large, we have 3 groups of anti-obesity medications. One is oral. Second, there are 2 types of injectable. One is daily injectable and another one is weekly injectable. Now, what we are currently using is weekly injectable, be it semaglutide or tirzepatide. Again, we have to choose selectively our patients who will respond to this molecule. We start with the low dose and escalate the dose up. And again, this is not a magic drug, remember, and it's not a what you call kind of a shortcut to diet and
Correct.
exercise, right? So along with this medication, they have to do diet and exercise, and when they're taking this injection, they have to follow certain instructions with diet and exercise as well, and they should have regular follow-ups. So probably for this patient, I would say let them do lifestyle changes with exercise and some low-calorie diet. They can focus on more Mediterranean diet, and we can try medicines in case after 6 months they are not able to lose weight with diet and exercise.
Then how are you going to deal with the patients who are 30 to 35 BMI?
30 to 35, at the first instance, I would probably consider starting a medication support, be it semaglutide or tirzepatide, and then along with diet and exercise is what I would suggest. What do you do for patients with BMI greater than 40 and people who have tried diet and exercise, and people who, there are a certain set of patients, around 4 to maybe 5% of people do not respond to these injectables, be it tirzepatide or semaglutide. You as a surgeon will require your help at that particular time. So how do you take that up?
See, my experience with obesity almost like 14 years plus. In Bangalore it's 11 years. So we do the highest number of bariatric surgery all over the south now. So as a corporate setup. So what happens is, I see a lot of patients who come, most of the patients they come 40 plus BMI, because patients who come to me, definitely they would have tried everything. All the whatever you said, they would have tried everything. And nowadays people are coming with people who have used injections, again when the weight gain, they come back to me. So finally ours is a long sustainable weight loss, because once you do a bariatric surgery, patients maintain the weight by 3 methods. One is, that's what I'm saying, body mass analysis when you do, there is something called BMR, basal metabolic rate. The surgery is the only way which increases the BMR, basal metabolic rate. Rest all the things, it may help in losing some weight, but they definitely not increase the BMR. Because patients who come to me like 50 year plus, they are unable to walk, they will definitely have low BMR, because of the age, the BMR is going to drop. People who have underwent hysterectomy, definitely they come with weight gain. So my surgery is a long-term sustainable weight loss because it increases the BMR. Definitely I am not against injections or tablets or anything, because definitely everything is designed for a specific people. Morbid obesity, I feel you should go with a long-term weight loss, which helps in other things also. For example, people who come with the BiPAP machine, post-surgery we stop them the BiPAP machine. Those patients, even the diabetic control will be there. People who are on insulin, high level of insulin, definitely shift to oral medications, cholesterols. All the parameters will get better. Recently, what I am getting patients is, patients are getting with marriage with PCOS, definitely they are going to marry, then unable to conceive. Those kind of patients requires a serious weight loss, significant amount of weight loss, because with the surgery, the weight loss is significant. Like they lose at least 30-40 kgs of minimum kind of weight loss they lose. So definitely once you see life in a different way, and many of the times my surgery helps in postponing the knee replacements. Because once a knee is damaged, definitely the knee has to be replaced. Those patients comes to us when they lose weight significantly, they postpone the replacement at least for 5 years. The mobility is increased. One is increase in sleep apnea. Apart from that, some patients come to us who has endocrine seriously issues like Cushing's. We definitely don't treat those patients. We refer back to endocrinologist. And endocrine, thyroid, I always tell them, most of the medications of you will come down, except thyroid medication.
See, it is autoimmune. We need to know that there are 2 kinds of things which are there in patients with overweight or obesity. One is autoimmune thyroid dysfunction is there, that is definitely. And anybody who is overweight or obese can have marginal increase in TSH levels. So if they belong to that category where they do not have Hashimoto's, it's only the overweight obesity which is pushing the TSH slightly on the highest side. As soon as they lose weight, it's going to come back. They will not require the thyroid medicine. But if it is Hashimoto's, as we know, Hashimoto's is a disease or a autoimmune thyroid dysfunction where the thyroid gland is actually not functional much. So the hormone requirement needs to be there for life.
Lifelong.
Yeah.
How much percentage you see Hashimoto's and how much percentage you see?
I think what I would see is maybe more of Hashimoto's is what I would see, and rest of them is all.
So 80-20.
No, very difficult to say, maybe 60 to 40 like that. We can say.
Yeah. So many patients you still feel they can stop the medication?
Yeah, because they would have been started on a very low dose of thyroid medicine, maybe 25-50, that will come down. So I think we had a very good discussion with Dr. Moinoddin. He's our metabolic surgeon here at Manipal Hospitals. I would like to end this podcast by giving some take-home messages. Number one, we need to understand that obesity or overweight needs to be treated to prevent complications, especially hypertension, diabetes, cholesterol problems, to prevent PCOS, as well as to improve the fertility rates in women, to prevent metabolic associated fatty liver disease, or fatty liver is what we call. Along with that, the snoring can be taken care, and we now have effective options for treatment of overweight and obesity. Those are medications. We should know that not everybody responds to medication. There is a few percentage of people or somebody who is BMI greater than 40 who do not respond to medication can go ahead with the surgery. The success rates are good. So I think you won't want to add anything
Nothing,
from your
madam.
side.
See, I should congratulate Dr. Anusha for really dealing this obesity burden of this area. I feel more than anything, along with the medication, the support what you give, like what is the physical activity you need to do, and what plus has to be added along with the medication is very important. I think you need to spend a lot of time, I think, for each patient. How much time you have average spend?
Yeah, we have to spend around 15 to 20 minutes.
So it's a big time for so many patients, and
Yeah.
it's a very hectic schedule. I think you're doing a fantastic job, madam.
Thank you.
Thank you very much.
Thank you so much.